important aspects for those patients. We'll see if we can elicit both of your opinions about the talks we've heard today. I can start with Dr. Amal. Professor Amal, we have spoken about the burden of the disease. You've actually shown beautiful examples of how that burden is actually overwhelming patients and family. And you have touched upon the topic of, taking this further into well-structured advocacy group. What is your view about considering when you do an advocacy group like this to actually reach out to one of those patients to become a voice of the disease? This is something I have seen when I was working in Canada. Patients are actually very upfront to be a voice of the disease, have their pictures on the educational booklet, even have some recorded interview. What do you think about this approach?
Thank you a lot, Dr. Mohammed. Regarding, as you say, the advocacy group and support group preparation, or just to implement what we talked today into actual steps for something that, like inshallah next year when we do the same activity, we will have it on real life. We need, I think, what you can see from the experience that we see people, how they manage. We need people who really have the passion and they want to start, and the system that they will to start, and the steps, and supports people with them. From patient side, the patient themselves, their parent, we can choose those who are really initiative and committed with their own, they are enforced or pushed by their willingness to help others. In the meantime, we have to make for them the steps, the system, how they will manage together the society for the nephro, hematology, genetic society, pharmacy, those societies who are, and the other societies, not the scientific, also the other non-profit, with the stakeholder, because all of them with the companies. Those together we can manage, inshallah, to make a steps-wise, like a team under special society.
Yeah.
The team will be representative by one of the parent or of the patient themselves. And from there we can go, hopefully.
Yeah. What do you think about avenues like having, because at the beginning when you try to generalize the idea, you will face a lot of difficulties, but sometimes smaller successes are good. So what if you actually have this collaboration among us, and then each center will identify one patient who is willing to do so, and he or she can become part of these discussions. And sometimes they actually say one thing that is going to save like a 20 minutes of counseling from a physician standpoint. When that patient, current or previous, explains the same thing to the new patient.
Yes, exactly. Yeah. Sometimes one of those, just to comment, one of those Telegram groups was with the mothers who had genetic disorder, and there is around 1,300 mothers in this group for PGD, the pre-implantation gene diagnosis. So all of those 1,300 mothers are having genetic disorder, and they want to prevent it in the next pregnancies. So one lady came in the group, and she said that, ladies, I am carrier. I turned to be carrier for sickle cell anemia, and I'm proposed by my cousin, and he turned to be sickle cell. And I come to the group just to ask you, because they told me that even if both of us are carrier, we can do prenatal diagnosis, we can do PGD. So as you say, one word from them, all of them, they told her, go ahead and do not marry him. Don't marry them because you are still on the safe side. All of them, all of the ladies, and all of them, they told her, if we know that we will suffer, we won't go ahead. the prenatal is not that easy, the PGD is not easy, and they turn her mind, you know, not like I sit with them half an hour or 1 hour counseling. The patient to patient ideas is really, because sometimes it will affect more than the others, but again, we need to be with them.
Yeah.
That's what I think.
So, Dr. Hafid, if I try and take your thought about, you know, how we left or were leaving the PNH session, we were transitioning from measurements of laboratory numbers into focusing now on what is important. We have done the heavy lifting all as a team by treating those patients with C5 inhibition, which has changed so many things. But now we're focusing on how we can tweak it, route of administration, maybe using proximal inhibitor. Do you actually think that at some point we're going to move from using a cutoff like hemoglobin value or LDH value to a quality of life measurement? Because you would agree with me that we will have two patients, one with a hemoglobin of 8 and has no symptoms, and another one with a 10 and he has all the symptoms, and they're both legit. They're actually delivering exactly how they feel. Do you think this is going to happen in PNH, where we actually would switch from one class to the other because of the true quality of life derangement?
I think with the future and evolution of new medication, I think it will be doable, or we can get it. And I was really planning to ask Dr. Hazza, but he left, unfortunately, regarding this target hemoglobin for this patient. We are treating patient with chronic disease. And you need to know what's your target to optimize your therapy for those patients. Is it figure hemoglobin like more 11, more 12, more than 11 or 12? Or is it symptom relief? The patient will, at this figure, he will feel happy, or will look for the chronic long-term complication, either with low hemoglobin less than 10, or if hemoglobin more than 10. All this, I think, should be fixed, and especially with this medication. Dr. Al-Rajhi, he talked about the combination therapy, and this is another area should be considered in those patients to get the optimal response and quality of life.
Yeah. Okay.
I have a question, if you don't mind, for Dr. Amal regarding the legal impact or consequence for participation of the healthcare provider, clinician, pharmacist, whatever, in this advocacy group. What is the regulation that protect the healthcare provider in this community if something like, you know, the capturing now the screen and the conversation, this will be some scenario like if some patient asked me about his case and I answered according to the question, but in reality his case is different than he mentioned, and sometimes he will complain against you. So is there any regulation that protects the clinician? Because frankly, we are scared to participate in one of the factors is this issue.
You are right, Dr. Yania. When I go in those groups, I didn't announce that I'm doctor at all. I announced that I'm with them, as I'm with them. I didn't lie, I'm with them. But some of them, when they go to me, like they ask me at the private messages that I would like to have a consultation. I apologize that I don't do online, but I guide them usually to where they can go. Some of them, when they insist, I try just to go, you know, to see what is going on, and again to guide them to go to somewhere. Because as you say, sometimes it is different entity, different. We are not going to give, and those are not going to give any treatment. It's almost, you know, it is for me as a geneticist, go to have genetic counseling, do this test, do this test. So no treatment, nothing to be managed by in those groups. But again, like I'm holding the Twitter account for the Saudi Society of Medical Genetic, and again they come us in the private messages asking for some questions, consultation, and again we apologize because of, as you say, as benchmarking we cannot do online. We need you to come. And the way that I managed with this actually in the Saha Virtual Hospital, because we manage in Saudi Society of Medical Genetics to make a deal with Saha Virtual Hospital. Whoever reach us in Twitter, we will send him to Saha Virtual Hospital, and we will have really, legal clinic. So I see the patient there. We manage like more than 70 patients to send them from Twitter to Sahha Virtual Hospital to genetic clinic. We manage to see the patient. Sometimes we do the test even, and we do the prevention. The other way around that we can do that in our inshallah planned advocacy group to be under a specific entity, societies. So there will be a group that it will have the questions and answer them privately and in a good context. Because doctor, you are having patient virtually. You are seeing virtual patients, so it is there. We have to face it. We are seeing patient virtual by phone, and they have to show us as much as we know as we can that this is the same patient, this is their results, to give them the right decision.
Okay. So I have a question for Dr. Hafid. Would you not find the incidence or the prevalence of PNH in the King's College study striking, because it's higher than what anybody would have assumed? Seeing this, can this actually inform the physician to test more, especially in cases of hypociliary bone marrow? Because as you mentioned, that it has double-edged sword thing, because when you actually so the PNH clone they're very protected, and when you give immunosuppressive therapy, they tend to thrive quickly. So that gives us an impression that they actually have a positive impact on response, but it's just because they don't die as easily as their progeny. Do you actually think when that happens, it is important to repeat the PNH flow to see the change in PNH clone size, and now the patient will require more routine follow-up, because as we all know, if the size of the clone goes higher, the risk of thrombosis can also be higher.
As mentioned, in MDS, anaplastic anemia is with positive impact on those patients, and the opposite in patient with MBNs, they will have a little bit more thrombotic complication. In the cases that in the recent in the second study, but I couldn't show because it was not clear. Some cases that with PNH disappear in cases with CML. The PNH clone disappear after diagnosis of CML and treatment. In other cases, the PNH rose after the diagnosis of MBN. So I think is to serve the follow-up for the PNH clone to get good background about this patient to expect the prognosis either bad or good.
Would you say even if they are JAK2 positive for the MPNs and they develop a thrombosis in an unusual site, should we not be proactive about it and do PNH clone testing? Because at that stage the treatment will be different, especially if it's a sizable clone. Although some experts say whenever there is a thrombosis and a major PNH clone, size does not matter. So it's like a chicken and egg thing, whether it's the MPN or the small PNH clone or both.
Yes, it's a gray zone. It's not that clear. If the patient without MBN with thrombosis at unusual site, PNH in addition to JAK2 should be tested too. But when you have the patient with MBN already known for many years, and then develop like unusual site thrombosis of an unusual site, I think they deserve to test it, because the treatment will be a little bit aggressive than without PNH.
Professor Ahmed, so hearing Dr. Hafid comments about evolution of the clone from one time to the other, is it like expected for a somatic clone to suddenly disappear? Like he was referring to CML cases, they had some PNH clone before, they developed a CML, that clone disappeared. Any scientific input into this phenomenon?
Actually, I have to say I have to read about it.
Okay.
Because it's really interesting when I'm hearing you what is going on, how I can convey it to other things that I deal with it. But sorry, I don't have an answer. I think I will read and find what is going on in this phenomena.
Yeah, it's fine.
Interesting.
The use of androgens is common in some of the genetic diseases, and Dr. Hazza, he is spiced up with a lot of experience from conventional era to the novel era. He talked about the use of androgens in hypocellular PNH cases. It helps with increasing cellularity. But I'm a person who would worry about using androgens because they have their own complications, liver toxicity. Even in a disease that is actually known to be prothrombotic, it may actually increase the thrombotic risk. Any insight from you about androgens in these cases, or is it safe to even discuss these with patients now we have more targeted therapy?
To me, the question, because
Yeah.
I'm not dealing with them. While you are talking with me, I want to again to ask, are those patients who are taking those medication, they are confirmed genetically with those diseases, isn't it?
So
With
we
some of
actually, that's actually a beautiful question, which brings up areas of unmet need. We don't actually do genetic testing because the literature has already established that it's a somatic disease. And it doesn't matter as, I forgot which, I think it was Dr. Ayman, he said it doesn't even matter where the hit is. We just measure the end outcome of that hit, which is the size of the clone. So we identify it by flow cytometry and then we treat.
But can we make sure that there is no like genotype, phenotype, or modifier somewhere that, because you are saying that and you are practicing there, some patients differ from others while they have the same hit at the beginning or at the end, but there is some difference between them. We are not checking that hit, where is it?
Absolutely.
So maybe if we have like genetic testing that can confirm for us in a somatic or germline level that this is can differentiate between them. Is there any some reports about this or some activity, research on it, studies?
I think the report, to my knowledge, and I'll leave it to the floor if they have any comment about it, or Dr. Hafid, it actually came up. When you read now new literature in PNH, it actually resurfaced again. People now are digging to go and find concurrent germline mutations because we used to say PNH is a somatic disease, period. But now we're seeing variations. We're seeing younger patients with it. So it actually resurfaced again.
Younger and familial.
Yeah.
So there's something, more than somatic.
Yeah.
Maybe.
It's very wealthy in AHAS, but not as much as in PNH, but it's coming back.
Just comment regarding the danazol. Dr. Hazza has, I have no personal experience with danazol. Just in regarding my fellowship with in King Faisal with Dr. Hazza, I think he has good cases, collection of cases on danazol, also Dabson in ITB and other conditions. And I think he has a good outcome. I'm not sure that, and this will depend on the balance between the benefit and the side effect. This is one of the old medication that have been used. In my slide, there was the first case, it was treated in 1979 with oxymethylone. And frankly, first time I heard about this medication and it's only in the first case. After that, was not used at all. So it depends on the balance between the benefit and the side effect between patient to another.
Yeah. Any other comment, questions that you'd like, you want to ask the panel? If not, I think these are the questions I tried to prepare. If no questions, we can actually thank the panelists and
I have a last, just one comment also, just to comment from our experience that sometimes we get one disease or like hematology or others, and we concentrate on it. And when we find another manifestation, we try to combine that one disease with those two manifestations. But with the more genetic testing and more time, we find that really the patient is suffering from two disease disorders. So it turned out like in our genetic clinic, around 10% of our clinic have two autosomal recessive disorders, which is really high, and really that make us need to think twice when we find two separate entities, that no need to combine them as we used to do it before. It may be really the patient suffer from two things. So this is, and this is our community, so I want to comment.
This is actually very important, and it's an eye-opening, because you're right. We always like to find that diagnosis that unifies everything, but genetic diseases, they can have a list more than one. Thank you very much, and thank you, Dr.
I
Hafid.
can ask just question regarding Dr. Hajar. Actually, we are in the MOH, or can see the peripheral hospital in the kingdom. Regarding, you are approving and funding high costly medication for PNH, but the problem, as you know, the PNH is rare and underestimated, and we have difficulty in testing availability. I ask your power, your authority in MOH to help us as clinicians and to provide these tests in our hospital, at least in one central hospital in the region that will be as a center for the testing.
Will do. أكيد إن شاء الله. بالعكس, this is something that يعني you captured before my presentation. Now we are in the final stages of releasing the rare disease registry. واحدة من ال two indications that we are capturing currently is PNH and AHS. And we are targeting these sites and understanding من الphysicians إيش الأشياء اللي ناقصة من عندهم في عملية الdiagnosis, أو whether it's lab, whether it's anything else that you require. بالعكس, أنت أصلا وجودك معنا. Thank you very much, and we'll definitely attain to your request. Thank you.
Okay, if no other comment, تفضل.
There are some examples that you showed, and almost like half of them are in a negative way regarding if somebody has a question, someone else will answer with a non-medical experience, and some other patient will give their opinion about any case. Especially in rare cases, when there are like rare diseases where there's no good sources of information for them. Our support group, the harm versus benefit for it. I know some people, when you try to connect them, some patients, when you try to connect them, the misinformation will spread more, especially the anonymity in Telegram. It's a double-edged sword. Like, it can be good that patient will feel safe to express themselves, but also it removes the accountability for others to give them any false information or any false hope. They will just feel more relaxed to give their opinion if it is not medical. Like, they'll try to give them زي مقولة المجرب ولا تسأل طبيب, فيقول we tried this herbal medication, we work with us, so multiple. So is there any study or is there anything that is showing, is it more beneficial or more harmful?
يعني أنت وقعت على الجرح. This is the wound. And I remember with Dr. Abdurrahman Swaid, Allah ذكره بالخير, he told me, Amal, whatever support group, make sure that there is no this backfire, because one of the parent will be like, or one of the family will have this, it is there. And I think this was one of the causes why we are, as doctors, were away from those support groups. And when you go away, somebody will replace your place. So either we will try to manage as we can, or it is there. The backfire is a lot. Every people would like to say, yes, I know. No one will say, no, I don't know. Everyone حيفتي على طول. But I find it, because I go in many of those telegrams, I find some of the, that when the admin is really clever and strong, like the support group for the متعافيات, I was with them for متعافيات breast cancer, alhamdulillah, we finished from it. So in that group, the ladies were really good that don't take any herbal. It will contraindicate your chemotherapy. So all of them, they have the same answer for anyone new who will come and ask, oh, I hear all of them, they have one answer: no herbal. So some of support group, they were okay, and you are proud that you find those people who are really, aware. And others, I was really surprised with the amount of people who are answering in some of the renal and some. Like with the stem cell, all of them, they don't answer. No, I don't know. They were so cautious with the stem cell transplant support group. So I think the admin is important. Being there, even without that, that you are doctor, but you give this impulse. Do not talk about this and a reinforcement of this. I'm not this, advocacy, or I'm أسوي دعاية للتليجرام ولا other, but I see that there is need and there is people that we need to connect some of them. Maybe this day was, why I come to this support group for the Telegram, for the renal, because of this day, I don't know about it, but I come and I'm planning to stay just to see if I can do something or not, and maybe we can do something. Yes.
Okay, so just stick with the time so we can conclude, because this is a very spiky situation, that it is a mean that we will have to use tomorrow, but as Dr. Hafid said, we have to put all the legal barriers to make sure it's done properly, and patients and relatives can actually benefit from that, and it complements the main message and the main care. Again, with that, we will conclude. Thank you very much for your participation, and thank you for having me today. Thank you.
Thank you, Dr. Mohammed, for this amazing panel discussion. Now moving to AHS.